Okay.
That's working.
Yes. I can see
Beautiful.
my notes, but yeah, that's good. Um, all right. So 14-year-old boy, 2 weeks of polyuria, polydipsia, has a 4 kg weight loss, complaining of 1 day of vomiting, diffuse abdominal pain, no diarrhea. These are his vital signs. A temperature of 36.2, heart rate of 132. Respiratory rate of 32, blood pressure 96/58, 99% of room air. He's lethargic but arousable, dry mucous membranes, no focal deficits. These are the labs that we get. His glucose is 612, pH is 7.05, bicarb is 8, anion gap is 28, beta hydroxybutyrate is 5.8, our BUN is 22, creatinine is 1.2. Potassium is 5.4, sodium is 132, chloride is 96. So what do we think is the diagnosis here?
It's okay, there's no problem. You can check it and write it now.
I can't see the chat in this mode, so.
Daniel, I think was trying to answer the question.
Oh,
Daniel, what do you think's going on with the patient? Anyone can chime
any
in.
guesses?
Polyuria, polydipsia, weight loss, abdominal pain, they're tachycardic, they're tachypnic. It sounds like they have Kussmaul respirations. And then on labs, they're hyperglycemic, they're acidotic, they've got an elevated anion gap, elevated ketones in the blood. They have a elevated BUN to creatinine ratio. They're slightly hyperkalemic. And the sodium's low. Thank you, Rebecca. They've got DKA. Yay.
Okay, thanks. Yeah, so they've got DKA, and specifically this is severe DKA, and we'll talk a bit about what that means later on. Um, Okay, so our second case is a 22-year-old woman. She has a history of type 1 diabetes. She has an insulin pump, 6 hours. She's coming with 6 hours of nausea, vomiting, shortness of breath, some redness around her infusion site. Yesterday, that's where her pump goes in. Her vitals, mildly tachycardic, heart rate of 108. Her blood pressure is 122/74. Respiratory rate is 22. She has normal mental status, normal oxygen saturations, no signs of shock. And you get some blood work on her, and her glucose is 384. Her pH is 7.22. Her bicarb is 14. Anion gap of 22, beta hydroxybutyrate of 4.2. And then you have potassium and sodium as on the slide. What do we think is going on here? Any thoughts on this one? Okay. There, let me see if I can access the chat.
I'll let you know if anyone chimes in.
Okay. All right.
So
Well,
this patient's less sick than the last one, right? But she also has hyperglycemia. She's
mhm.
acidotic. She has elevated ketones in her blood. What do you think the diagnosis is? Yeah, thank you, Prosper. Still looks to be DKA, probably failure of insulin pump.
Yes, perfect.
Nice.
Yeah, so this is DKA, just a milder form of DKA. And this is another patient. We have 4 cases, so 2 more. 72-year-old man, history of type 2 diabetes, recent UTI that went untreated, brought in by his family, with history of 1 to 2 weeks of progressive weakness and confusion. His wife said he hasn't been drinking much water. Vital signs, his temperature is 37.4, has a heart rate of 118. Blood pressure of mildly hypotensive, 92/54. Respiratory rate is 18, oxygen saturation is normal, and his glucose is greater than 500. This is when you check a finger stick and it says high, and you don't get a number sometimes. So his physical exam, he's confused. His GCS is 13. Very dry mucous membranes, no Kussmaul breathing, cool extremities, weak pulses. And then you get some blood work. His his glucose is 894, pH is 7.34, bicarb is 22, anion gap is 14, beta hydroxybutyrate is 0.6, and his osmolality is 342. What do we think about this one? What's the diagnosis here? HHS, yes. Yeah, so he has HHS, yes, because of the neuro changes, very good, because that's a hallmark finding of HHS. He also has markedly elevated blood glucose levels. And you have a normal anion gap, a normal beta hydroxybutyrate, which is different from what we saw in the first two cases where you had elevation of those numbers, elevated anion gap and elevated beta hydroxybutyrate. You notice here that his pH is also within the normal range, while with those patients, it was very low. So this is HHS, and those are some of the key differences between them. Now, this is another presentation. So we're doing a series of cases that show you different ways that hyperglycemic emergencies can present. This is a 54-year-old woman. She has a history of diabetes. These are some of the medications she's on. She's on metformin and empagliflozin. I don't know how to say that right. But she's 2 days post-op from a lab chole. She's now presenting with nausea, malaise, vague abdominal discomfort, mild Kussmaul breathing. Her vital signs, she has a heart rate of 104, blood pressure of 118/72, respiratory rate of 26, temperature of 37, oxygen saturation is normal. Her blood sugar is 184. So they did not start a DKA workup. But when you order labs, you have a blood glucose still at 184, a pH of 7.18, bicarb of 12, anion gap of 22, beta hydroxybutyrate of 4.8, lactate of 1.4, and a normal lipase. What do we think is going on here? This is a little bit of a tougher, less common presentation. Euglycemic DKA, thank you so much. Perfect. So this is when you have DKA without your classic glucose elevation. And we'll talk about why that happens. And the key, one of the main reasons why this happens is the medication that this patient is on. So empagliflozin is an SGLT2 inhibitor, and these patients are generally prone to having euglycemic DKA. And there are some other reasons why that can happen. So let's go through DKA and HHS. DKA stands for diabetic ketoacidosis, which I love because it just tells you almost everything you need to know about DKA. So diabetes, so elevated blood glucose, ketones, elevated ketone levels, acidosis, you have acidosis. So, and those are your three diagnostic criteria. So everything is in the name with DKA. Hyperosmolar hyperglycemic syndrome, also preferred because it tells you have elevated serum osmolarity, severe elevated hyperglycemia. The one thing that is not in the name is your altered level of consciousness. So I think that these are very well named as opposed to many other things in medicine. But these are two distinct entities. They exist on a spectrum and you can actually have a little bit of overlap, but these are the two classic hyperglycemic emergencies. That's blood glucose being high in patients with diabetes. This is as opposed to hypoglycemic emergencies, which is really your blood sugar just being low. So this hyperglycemic emergencies account for more than 12% of diabetic-related admissions. I was looking at a study done, like a recent scoping review, to try and characterize the incidence of this in Africa, and there's a wide range just depending on where you study it, what setting you study it. There's a range of, for DKA, it's like 2% all the way up to 92%, resulting in admissions for diabetic patients. And then HHS is less frequent than DKA, but also you can have that from 4% to 50% of cases. It presents very significantly among children and adolescents as their primary diagnosis of diabetes, constituting up to over 70% of pediatric endocrine admissions. Mortality is a big concern with these emergencies and is documented in sub-Saharan Africa to range from 26% to 40%. This is notably more or higher than in other high-income countries, and is thought to be driven by some delayed diagnosis and delayed treatment that could occur in these settings. So if we talk through the pathophysiology of decay, this is classically younger patients. So you can see this in children, adolescents, young adults. Is classically in patients with type 1 diabetes. However, this dogma has been, challenged because we see decay all the time in patients with type 2 diabetes. So we shouldn't always think about it in type 1, but it's way more common in patients with type 1 diabetes. And what happens here is, like in patients with type 1 diabetes, they have almost a near absolute insulin deficiency. So you have very low amounts of insulin in the blood, meaning that insulin is a hormone that allows the cells to take up glucose. So glucose is needed for cellular functions. Insulin drives glucose into the cells. And when insulin cannot do that, or where there's not adequate insulin, you have counter-regulatory hormones. And these hormones include glucagon, cortisol, catecholamines, growth hormone. All of these hormones try to increase the amount of glucose. So because it senses that, the cells they can't receive glucose, so they sense that as starvation, right? So these hormones try to increase glucose in the blood, and it does this through different mechanisms. So one of them is gluconeogenesis, that's production of more glucose, glycogenolysis, breaking down of glycogen to form more glucose, and then lipolysis, this is breakdown of fat cells. And what happens when you break down fat cells? You have free fatty acids, and this generates ketones in the liver. You have three kinds of ketones that are generated: beta hydroxybutyrate, acetoacetate, and acetone. And this becomes more, this is good to know because when we talk about diagnosis, we'll recognize what our different assays measure. But beta hydroxybutyrate is the dominant ketone that is formed. So you have two main problems. You have a lot of blood glucose in the bloodstream because of a lack of insulin. And what that does too is that it increases the osmosis. So glucose is pulling fluid into the intravascular system. This is causing diuresis, and you're losing free water and you're losing electrolytes as well. So there's a lot of fluid loss and electrolyte loss that happens in DKA. And then you have another problem is you have all these ketones being formed, and ketones generate, they cause acidosis because they're acidotic. So they generate this high anion gap metabolic acidosis. Acidosis is not good for the body. We know that the body likes to maintain a state of homeostasis where everything is within, certain ranges. So all of this the body tries to compensate for this by breathing fast, so trying to blow off some of that acid through respirations, and you have what we call Kussmaul respiration. So these are the different factors that kind of play together to form, to cause the syndrome we know as DKA. In HHS is a little bit different. This is classically in older patients with type 2 diabetes. However, we know incidence of type 2 diabetes is increasing in children and in adolescents. So you can also have HHS in this population as well. So what you have here is there is some insulin as opposed to DKA where there is almost absolute deficiency. Here you have some insulin, but it is counter-regulated by a high number of those hormones. So the hormones we talked about, glucagon, catecholamines, you have a higher amount of those hormones, so that causes a relative deficiency of insulin. And this happens for different reasons. More commonly, there's some stressors. So this could be sepsis, it could be dehydration, it could be a stroke, it could be something that triggers all of those hormones to spike. causing this imbalance. And same thing happens here where those hormones cause, the production of glucose. You have gluconeogenesis, you have glycogenolysis, increasing the amount of glucose in the blood. But the difference in HHS is that you still have insulin. So you have enough insulin that you suppress that fat breakdown process. So you suppress lipolysis and ketogenesis. So you don't have the acidosis, you don't have the ketosis, but you have very elevated glucose levels. You have that osmotic effect, you have that loss of water and loss of electrolytes as well. This is a more progressive disease than DKA classically. So this is just a chart that kind of puts the two together and shows you where they're, the common pathway. You have elevated counter-regulatory hormones, and you have either an absolute or a relative insulin deficiency. I won't go through everything on the slide, but I just wanted to show, kind of where this differs. And there's that part in the middle where you can have a bit of overlap. The difference being that the DKA part will have the ketosis, and the HHS doesn't really have that ketosis. So talking a little bit more about the electrolyte derangements that we see, one of the biggest one that we worry about is potassium, because we know potassium affects the cardiac cells, cardiac myocytes, and we lose a lot of potassium due to the osmotic diuresis. Patients with DKA also have a lot of vomiting, so that's another way that we lose electrolytes. So hypokalemia is very common. The thing to note with hypokalemia is that the serum measurement might be normal, and that's because potassium shifts out of the cell. So the potassium comes out of the cells into the bloodstream, and it gives you a falsely, normal or even elevated level. But just note that they definitely have total body loss of potassium. Other electrolyte derangement could be hyponatremia, and we call that a pseudo hyponatremia because it's not truly low. It's more of a dilution effect from all the increase of glucose in the bloodstream. Then your phosphate levels could be low as well. Magnesium levels could be low. So how does this present? With DKA, you have polyuria, polydipsia, all of that diuresis. So they're peeing a lot, they're urinating a lot, they're drinking a lot of water. This results in weight loss. And with that acidosis, they have nausea, vomiting, abdominal pain. Then classically, they have the Kussmaul respirations, which is them trying to compensate for that acidosis by blowing off CO2. On exam, you can see dry mucous membranes, you can have tachycardia, you can have either hypotension or hypertension, and it's paradoxical having hypertension in these patients, knowing how much fluid they've lost, but that is because there's all of this catecholamine surging, and then also there's that osmotic effect of glucose in the bloodstream, drawing as much fluid as possible. So all the cells are dehydrated and all the fluids are just in the intravascular system. So you can have a normal to high blood pressure in these patients. And then many times there's a trigger for DKA or HHS. So you can have symptoms of those triggers. So if it's an infection, you can have fever, you can have symptoms of a UTI or a pneumonia or any of all those other things. The red flags or things I wanted to point out are things that you should pay attention in DKA. If they're getting, so HHS has altered sensorium. It's not as common in DKA, but when you have a DKA patient presenting with a GCS less than 14, or they're getting more somnolent during treatment, they have focal neurologic deficits, severe headache, vomiting, we're starting to think about cerebral edema, which is a condition that DKA patients are prone to when we start rehydrating them and giving them insulin. So these are some of the risk factors for cerebral edema. It's more common in children, and these lab values, children less than 5, and these lab values put them at higher risk. So HHS is usually a slower, more insidious disease, like in the case that we talked about, someone presenting with weeks of weakness, weeks of, not drinking, not feeling well. There's some weight loss. There's also some polyuria, polydipsia. But since this tends to happen in older patients who may not be able to care for themselves, it's often a more delayed diagnosis. So it presents when people start to notice that, oh, they're altered, they're no longer responding, they're super sleepy. So this tends to be a more delayed diagnosis and just a slower process in general. And of course, they can have symptoms of the trigger as well. This is more common. This more commonly has triggers like infections, MI, stroke, pulmonary embolism, medications that they might be on. These patients are classically very, very dry. So you have very dry mucous membranes. Tachycardia and hypotension is common. They can have delayed capillary refill. But it's important to distinguish from DKAs that they don't have acidosis, so they don't have the Kussmaul respirations, and they might not have as prominent of abdominal pain or vomiting symptoms like DKA would have. So how would we manage this patient? So some tests I would like to get EKG because they're prone to electrolyte derangement with potassium. So we want to look at that. We want to check glucose, their electrolyte, ketones. Depending on how you check ketones at your institution, serum ketones are preferred, but you can also get assessment of ketones from the urine. The urine test for acetone, which is not the most common. So we talked about beta hydroxybutyrate and acetone being some of the ketones that are formed. The urine tests acetone, while the blood tests beta hydroxybutyrate. Beta hydroxybutyrate is overwhelmingly the ketone that is produced. So urine analysis might underestimate the amount of ketonuria that you use, but using that in combination with your basic metabolic panel can help you make that diagnosis even if you don't have serum ketones available. Other things to check, because the trigger is pregnancy, you want to check a pregnancy test, check for other electrolytes and things that can help you know what is causing this. So talking about the criteria, so the most common criteria are these three up here for the diagnosis of DKA. You have a hyperglycemia, glucose greater than 200, acidosis, that's pH less than 7.3, or bicarb less than 18, and then you have ketosis, that's beta hydroxybutyrate, which is preferred, but you can have, if you have 2+ ketonuria on your urinalysis and on your dipstick, that's a diagnosis of ketosis, and you can make the diagnosis of DKA with that. And then you can grade it based on this. So mild would be bicarb less than 18, moderate a bicarb less than 10, and severe bicarb less than 5. So an iron gap is typically elevated. This is something that is newer. It's not required for diagnosis. And if you have a severely elevated anion gap, you should think of something else other than ketones. So you can have lactic acidosis, and that could be either because sepsis is a trigger for the decay, or just from a hypoperfusion from all the fluid loss. You can have lactic acidosis build up as well. So when pH is not available, your serum bicarb on your basic metabolic panel is sufficient for diagnosis and grading. So HHS, these are the criteria for HHS. It's 5. So you have to have that glucose level, and it's much higher. So with DKA is 200. Here you have 600. Your pH has to be normal, like it cannot be less than 7.25. Your bicarb, because you want to eliminate that acidosis. So pH is greater than 7.25, bicarb is greater than 15, and then you have that osmolarity greater than 320, and you also don't have ketonemia. So I would say the way I think about it here is that you have glucose greater than 600, you have serum osmolarity greater than 320, and you don't meet criteria for decay. That's what the other numbers are essentially telling you. Then you have HHS. This is how to calculate your effective osmolarity. There's this formula that you can use. MD-Calc is a great way. I don't know how many of you use MD-Calc. Can you put it in the chat? I think it's a great way to look up some of this criteria, and also to do some of the calculations, like calculating your corrected sodium in the case of pseudohyponatremia, or correcting your osmolarity, so that you don't have to memorize all formulas. Then sometimes you can have a mixed picture where you have up to 27% of people meet decay criteria and also have elevated osmolarity. So this can be a challenging patient to manage. I would say this is where someone that is an expert at managing this patient might need to be called in. So an endocrinologist could have input in this situation, especially if they're very sick, or a critical care physician at this point, because you kind of have to manage both pictures at the same time. Some other more complex presentations, you have euglycemic decay, which we saw a presentation of. This is where you have the criteria for decay without the hyperglycemia. So your glucose is normal, but you have the acidosis and you have the ketonemia. The primary cause is patients that are on this class of medications. So your medication history is very important. You can also have patients that are not on the medications. They have decay, but maybe they haven't been eating high carbs, meals that are high in carbohydrates. Maybe they've been fasting for some reason. So you can have a blood glucose level that is deceptively low, even though they're having all the other symptoms. And then also just a note about ketone testing, that you can have some false positives. So this is where you don't just look at the numbers, you look at the general picture, the history, your examination findings, and your lab findings to put everything into context. So your management, A, B, C, D, E, just like with any patient, manage their airway. Like we said, in HHS is more likely to present with, significant depression of mental status where you might consider intubation. But generally, you want to avoid intubation in DKA patients. They are so acidotic that it's very hard to match their rate of, they are so acidotic that they are breathing very fast. They are hyperventilating to compensate for that acidosis. And then when you paralyze them and you take away all of that drive, their acid drops really fast. So they become very acidotic, and this can lead to cardiac arrest in these patients. It's also hard to manage them on the ventilator. It's hard to breathe fast enough for them on the ventilator to counteract or to match how they were breathing when they were awake. So generally, it's not a good idea to intubate this patient, but if it's necessary, they're severely obtunded, they're vomiting, and you have to protect their airway, just do it with caution. And this is where we might consider a push of bicarb, even though bicarb is generally not recommended in DKA management. And then, of course, we want to check their breathing, circulation. We'll talk about fluid management in a bit, disability, their mental status, exposure. We want to look for, like the patient, one of the cases mentioned some redness around her infusion site. So you want to see, is this a skin infection as well? In that case, it's more likely that, it had just pulled out and it wasn't delivering the insulin, but it could also be that she had developed a cellulitis or a source of infection. So we want to do a thorough examination of our patients because, like I said, if as in a patient that is already diagnosed and on management, most times there is a trigger for it. So the goals of therapy, we want to restore volume, we want to correct electrolyte deficits, we want to reverse acidosis, and we want to identify and treat the precipitants. Okay. Oh, okay. Sorry, I saw some things in the chat.
Oh, I was just kind of touching base with everyone. I do apologize that we had put milligrams per deciliter as the units on the slides, but just for context, 13.9 millimoles per liter is the same thing as 250 milligrams per deciliter. So when you're seeing these really high numbers that Dr. Faith is presenting, it just should tell you these people are hyperglycemic. So follow your local guidelines in terms of what the cutoff is for diagnosing DKA and at what point you transition to dextrose containing fluids. And she'll get to that in just a little bit.
Yeah. Thank you for pointing that out. Yes. Yes. Okay. So, so the first goal in managing this patient is to manage the circulation, so to restore volume, because dehydration and shock is the biggest threat to them at this time. So normal saline is okay. There's some studies that show that balanced solutions such as plasma light or Ringer's lactate may be more beneficial, but there's been no studies to show that there's some mortality benefit or anything. So I would just start with normal saline, whatever you have available, and just try to restore volume. So there are different guidelines or recommendations on how to do this. Most places will say just start with like a liter of fluids in an adult and then reassess. If you feel like, oh, they're dry, they have tachycardia, they have dry mucous membranes, you can continue resuscitating and then okay, my next slide talks a bit more about that. So starting crystalloid resuscitation, you can start with 1 to 1.5 liters and repeat until, they are hemodynamics is stabilized. If they are not in shock and you feel, you feel like they're relatively euvolemic, you can start with a smaller bolus. Or in pediatrics, you do that by weights, of course, to do like 15 to 15, 20 meals per kilo. You can do this over an hour, do this over 30 minutes. Guidelines differ on that. The key thing to note is that with HHS, you anticipate a bigger volume loss. So these patients will need more fluids than your DKA patients would. And then for maintenance as well, so you can also, there are different ways to think about how to continue the maintenance after that initial resuscitation. And one is to just set the rates and say, okay, I'm giving 100 to 150. That should be about 2 times maintenance or 1.5 maintenance over the next 1 to 2 days. There are like methods like doing a 1 bag method or a 2 bag method, which I initially put on the slide, but I recognize that it's difficult to explain the 2 bag method because it follows like a table. If the glucose is this, then you increase the rate by this. But if that's what your institution uses, then there will definitely be a protocol on how to do that. So there are many ways to get this right, but essentially you want to think about replacing the losses that this patient has and then increasing the maintenance, because as long as the blood sugar is high, they're going to continue to diurese. And then thinking about the electrolytes, so I put electrolytes before insulin because the one electrolyte you want to make sure that you check and replete if needed is potassium. So if potassium is less than 3.5, you cannot give insulin at that point. You have to replace it and you have to recheck the number and make sure it's greater than 3.5 before you start giving insulin. And then there are these ranges. So if it's 3.5 to 5.5, you can start insulin, but you're giving supplemental potassium. If it's greater than 5.5, you can start with insulin and you recheck the potassium later on. And the reason why this is important is insulin, like insulin.
Mpabu earphone.
Okay. Insulin gets glucose into the cells, but insulin also drives potassium into the cells. So if insulin drives potassium into the cells, you have hypokalemia, which can result in cardiac arrhythmias. So how you replace, it depends on what your protocols are and what you have available. I would say that oral potassium might be difficult in patients with DKA because they're vomiting, they're sick, everything is not, it's not the way it should be. So typically we correct this IV and you want to do around 10 millimoles per hour in some institutions. If you're doing a higher rate, you probably will need a central line for this. Then for insulin, so insulin should be after fluid resuscitation. A few guidelines mention that you should try to start this at least an hour after you've started fluid resuscitation. It's not a hard cutoff, like you have to wait an hour, but the idea is if you start giving insulin and you haven't checked or corrected your potassium, you run the risk of hypokalemia, and you also run the risk of precipitating shock as well, because remember, glucose is osmotic. It is maintaining that blood pressure, and if you drive it all of a sudden without replacing the fluid that they've lost, they can go into hypovolemic shock. So you want to start insulin after they've been somewhat resuscitated. The standard dose is 0.1 units per kg per hour of regular insulin IV. You can go down to 0.05, and you can do this in cases like, oh, they have euglycemic decay. It's a smaller person, maybe they weigh less, or you have some other concerns, maybe they have renal failure or some other things. You can do 0.05 to 0.1. Again, this will be based on what this should be based on your institutional protocol. And then when your glucose reaches a certain level, then you add D5 because you want to continue the insulin until the DKA is resolved, but you also don't want them to be hypoglycemic. So you provide them with supplemental glucose. If a patient has a pump, we should turn off that pump before starting insulin. And then when do we say the DKA is resolved? So we're classically taught that when the gap is closed, your DKA is resolved. But we've seen, and one of the papers that was, sent to the group talks about, that's an unreliable measure because especially when we use normal saline causes like a hyperchloremic acidosis, and then you can continue to have like a persistent gap even if your DKA is resolved. So we have 3 criteria that we can look at, and if 2 of those 3 are normal, then we can say our DKA is resolved. So if your bicarb is now greater than 18, your pH is now greater than 7.3, your beta hydroxybutyrate is less than 0.6, you can say that DKA is resolved and we are transitioning to a more regular management. So that would be regular management of insulin would be subcutaneous insulin. Both the short acting and the long acting. So you want to give the long acting before stopping the drip. So maybe about 2 hours, 1 to 2 hours before discontinuing the drip. You can actually even give studies have shown that it doesn't hurt to give the long-acting insulin earlier in the course, and that's one of the papers that we'll talk about as well. So you can give your long-acting. It helps with faster resolution of DKA, and it helps to prevent that rebound DKA. And then the dose, of course, you either use the dose that if a patient was on insulin before, you want to start with their home dose, or if not, this is a dose that we can start with. That's 0.15 to 0.3 units per kilo. Okay, so some other management. So bicarb almost never indicated. Only consider if your pH is very bad. So you have a pH less than 6.9, maybe you need to intubate them, or they're in life-threatening hyperkalemia, you will need something to temporize them. But generally, it hasn't shown any benefit, and it has shown some potential harm. So something I would stay away from. Other electrolytes like your phosphate and your magnesium is usually a little low, but many times you don't need to replace them unless they're severely low. So here, if your phosphate is like less than 1.0 or your magnesium is less than 1.2, and maybe with associated symptoms, then you can also replace. These things generally correct as the decay starts to resolve. Okay, so management of HHS is the differences would be that there is no acidosis, so there's not as much hurry to start insulin. So with this patient, you want to go with fluids and fluids and fluids. So you want to rehydrate them. And the guidelines actually state that you start insulin when their glucose is no longer dropping with fluids. And we know this when we start rehydrating patients, their blood sugar, which might have been 600, might drop to 550, or after like a liter, and then it drops to 500. So if it stops dropping, then okay, we've gotten some headway on the rehydration, then we can start with insulin, and then we start with a lower dose as well. Same things, we always have to check potassium. And the big thing with this, aside from fluids, is more priority, is that we want to make sure that we're identifying and treating the underlying cause in these patients. So underlying cause, we're thinking of infections, thinking of people that missed their insulin, the pump failed, they forgot their doses, they didn't have access to medications for whatever reason. Other things could be ischemia, so stroke or cardiac or heart attacks can trigger DKA, intoxication, pregnancy. So this is like a mnemonic that says 5 I's plus drugs is a way to think about some of the causes. And then when you have a patient that keeps coming back with DKA, this is someone that you don't just want to discharge, but you want to think about, talking to social work, talking to pharmacy. Is it education that is a problem? Is it access to drugs? Like trying to figure out what the reason is behind this is important. Okay, so generally, how do we monitor these patients? We should be checking their vital signs. We should be put them on a cardiac monitor, especially if they're hypokalemic. We should be checking blood glucose every 1 to 2 hours and adjusting our fluid rates accordingly. Then our electrolytes should be done every 2 to 4 hours, especially our potassium. Then we want to monitor their mental status. If you start to have a change in mental status, we're concerned about cerebral edema. I mentioned earlier that this is more common in children, especially children less than the age of 5. This is more common in new onset diabetes, people with severe acidosis, severe hypocapnia. So you want to keep an eye out for these patients. So these are some diagnostic criteria. And essentially, they just talk about altered mental status, change in your neuro exam. Then you have headache, vomiting, lethargy, and then some risk factors. So if you have any reason to think about cerebral edema, the goal is to treat first, not waiting for imaging, because CT scans can miss up to 40% of cerebral edema, especially in children. So if you suspect cerebral edema, stop the IV fluids, elevate the head of the bed like we would do for an raised intracranial pressure, so like up to 30 degrees, and then we want to give a hypertonic solution. So that's either mannitol or hypertonic saline as quickly as possible. You can repeat this after 15 or 20 minutes if you don't have a response. You want to maintain normal blood pressure, and then if they're intubated, you don't want to hyperventilate, but you want to target their whatever their PCO2 level was before intubation. So special populations to think about: DKA can occur in pregnancy, even at lower levels than 200. So that's euglycemic DKA that we talked about. And this, of course, has high mortality rates for the fetus. So we would manage this typically the same way we would manage DKA. The difference is that we want to monitor, want to be checking on want to continue fetal monitoring, especially if they're greater than 24 weeks. With ESRD, the difference with this is patients that have end-stage renal disease on hemodialysis, they are not making as much urine, or they are making no urine at all. So we talked about osmotic diuresis being the key pathophysiology why these patients are losing fluids and losing electrolytes. So if they are not urinating, then they are not losing fluids. So they don't necessarily have the same volume deficit that other patients have. They might still have some because they might be vomiting, they might be losing fluids from other means. So I would start with much smaller boluses in this patient. So 250 to 500 ml boluses, and you are reassessing. This is a patient that you might need to diurese early especially if they're having severe acidosis or hyperkalemia. And if you're giving them insulin, you're starting on a smaller dose as well, because we know insulin is metabolized by the kidneys. And since they can't do that, they would, store insulin much longer than other patients. Patients with CHF, similar as well. They have a tendency to get fluid overloaded, so we just want to be more cautious with fluid boluses in these patients. The other thing to think about is if they are on medications like an SGL2, we want to hold that during the course of treatment and then reevaluate before starting again. Because we want to think about our elderly population. Think about comorbidities. They can hide disease much longer. So we have to have a high index of suspicion. And then we've already talked about euglycemic decay associated with SGLT2. So classically, patients with DKA are admitted, or severe decay, classically, patients with DKA are admitted to the ICU because of the insulin infusion. And that's one of the things that we'll talk about extensively with the paper. But just to say that patients with severe decay should still go to the ICU here. Mild to moderate decay would depend on your institution. So if you have a step-down unit that you can go to, if you have an observation unit, if you have a medicine floor, this is very institutionally dependent on the resources, the comfort of the physicians and the nurses. I would love to hear how you guys manage it. Do you generally admit DKA to the ICU? I would say when I was in Nigeria, I trained at Luth, and we had like very few ICU beds. So those were very reserved. They were reserved for very ill patients, and we usually did step down. So I'm curious as to where most people admit their DKA patients to. Very unlikely that these patients will be discharged. But if they end up staying in the ER for a long time, you have long boarding times, they're there 12, 24 hours, you've managed the decay, there is no, it's not precipitated by like an infection or ischemia or something. And maybe this is someone that missed their medication, or they took expired medication, and you've solved the problem by giving them medication. Then this is someone that we can consider discharging with very close follow-up. But generally, this patient tends to be admitted. I'm just going to look in the chat to see if anyone has said.
It looks like Richard says they're always admitted to HDU, which I think is their equivalent of ICU.
Is it ICU or step down? I think HDU is more like it.
Richard, do you mind chiming in? Is HDU kind of like the step down unit, or is that close to ICU?
Essentially, what HDU means is a kind of environment that has resources almost close to what obtains in the ICU, but having some resources not there as much. It's called high dependency unit. Perfect. Okay, over to you.
Appreciate it. That's a helpful clarification. Yeah, and then it looks like Rebecca just put some great questions in here. So would love to know how IV fluids and insulin can be safely given in places without infusion pumps. Yeah, this is the challenging part. And so I think subcutaneous insulin would probably be a safer approach if you don't have an infusion pump. And we're going to talk about the SQUID paper in just a few minutes. It's the subcutaneous insulin and DKA paper. And I believe their protocol is either in the paper or in the appendices. And then how do we manage patients on medications who come in with hyperglycemia and not in DKA or HHS? That is a whole nother bag of worms, Rebecca, and definitely challenging. I will say if someone is at their baseline, so maybe they run around with a blood glucose of like 15 millimoles per liter all the time, and they're not in DKA, I'll look at the patient and determine whether I need to give them a dose of subcutaneous insulin in the emergency department. But if they're in their baseline, sometimes I don't do anything about the sugar because they're always running around like that. So it depends on the situation. Like if the patient is there for something else and they're incidentally found to have hyperglycemia, maybe they're here for foot pain and they just like stub their toe. I don't necessarily need to fix the sugar if they're always hyperglycemic, but if a patient's being admitted to the hospital for for something else, let's say for a heart attack, and they also have hyperglycemia, then yeah, you do need to improve their blood sugar while they're in the hospital. I probably would not start an insulin infusion for that if they're not in DKA because it's a lot of work for the nurses. And it's a lot more resources. So I would say sliding scale and long-acting insulin. So like subcutaneous insulin would be preferable. Emmanuel, if you want to chime in on that in your setting, if you have different thoughts, that would be great.
Go ahead, Jess. Because of want of time, all my comments, I'll pass it to you.
Sounds good.
Directly.
All right,
Okay.
Faith's going to start talking about the SQUID protocol, which partially answers Rebecca's question. Go ahead, Faith.
Yeah, I'll start talking. The one thing I wanted to add to that is I would, if they're getting discharged, I would think about what their follow-up is like. So maybe you can just find out if they had insulin or they don't have access to it. So just trying to troubleshooting why their blood sugar is high, but not necessarily doing anything about it. Okay, so this is the exciting part of the talk. This is the SQUID protocol, subcutaneous insulin in DKA. So this paper, so like we talked about, DKA is traditionally treated in the ICU because we're doing insulin infusions. And this is very challenging because ICU is a precious resource. We don't want to use it except absolutely necessary. There are all the complications with monitoring blood sugars, monitoring electrolytes, and all the things that come with managing DKA on and using insulin infusion. So this paper wanted to look at using subcutaneous insulin. So that's both long-acting insulin and insulin analogs, seeing if we can safely use this to manage DKA patients. So they targeted patients with mild to moderate DKA to reduce the need for ICU admission and also reduce the length of stay in the emergency department. Because if there are no beds in the ICU, then the patient sits in the emergency department until there's a bed. So there were some previous studies that had tried this out and they saw that there was no negative impact. So patients had the same amount of time to DKA resolution. They had the same amount of incidences of hypoglycemia, which is something that we want to make sure we're not making our patients more prone to. And they had similar length of hospital stay. So they wanted to look at this question. So this was a prospective study. They developed a protocol for this, and I think the protocol is on the next slide. They developed a protocol, educated people on it. They recruited people. So they did this in adults. So adults greater than 18 with mild to moderate DKA. This is the criteria. They excluded people with severe DKA, people that were pregnant, sepsis, serious infection, or essentially something else that would require critical care management. So this is just straightforward mild to moderate DKA patients. And then they also, so they put this patient on this subcutaneous protocol. They had a group of patients as well that went on the standard protocol, and they did what they called historical control. So they compared the management of these patients to management before the protocol was instituted. So this was pre-COVID. So they did a pre-COVID era and they did like an after COVID era. So basically just comparing to what had been done in the past. So this is the activation protocol and this is what they did. So when they found the diabetic patients that met the criteria, and had no exclusions. They essentially started with a 2-liter bolus of fluids. Then after that, depending on what their blood sugar was, they would give insulin, short-acting insulin. Here they use insulin Lispro. So if it was greater than 250, they would give this amount, and then they would start fluids at this amount. And then if it's less than 250, so this was a protocol that they trained their staff on and instituted in the emergency department. The thing to note is that they still had to check blood glucose every 2 hours to make sure that there was no hypoglycemia, or they could correct it early if someone was trending downwards. They also checked their basic metabolic panels every 4 hours and replace potassium as needed. So because of this protocol, they were able to manage the patients on a general medical floor. So their goal was to evaluate the impact of this. And I mean, their main goal was to see if it would reduce emergency department length of stay, actually. Okay, so that's their primary outcome. Other things that they were looking at, they wanted to make sure glucose were being checked regularly because that's a concern. They wanted to look at ICU admission rates and the safety of this. This is the statistics that they used. So they eventually enrolled, so they screened 218 patients. 177 had mild to moderate DKA, 78 ended up on this protocol, 99 ended up on the traditional pathway, and then they had different numbers in the historical controls as well, 163 versus 161. So they realized that the patients that met criteria for these protocols were typically younger patients, and more often female. This was more of an African American population, and that's just the environment that they lived in. And so by design, it excluded sicker patients, of course. So what their results were, median length of stay. So with the script protocol, you had a shorter time. So you had 8.9 hours compared to 11 hours in the other 10 to 12, I would say, for the other periods. The important thing, I know this was their primary outcome length of stay, but I think what was more interesting to me was to see that they did not have more episodes of hypoglycemia in this case. So they used rescue dextrose for 2 out of 73 patients, and in the traditional pathway it was 1 out of 28. So I would say that that's almost similar. So these patients were not at more risk for hypoglycemia. They were still able to get their glucose checks and their BNP checks. So their performance in that sense exceeded the protocol target. The ICU admission rates were, there was no difference in patients that were on the protocol and then needed to be admitted to the ICU. They did note, if you read in their discussion, that the patients that were on the protocol and eventually needed to get admitted to the ICU was usually because someone did not check the blood sugar. Someone did not check the blood sugar on time, and then they got recurrent hypoglycemia, or they did not start the basal insulin when they should have started it. So that's the long-acting insulin was not started appropriately, or they missed one of the short-acting. So it was usually some error in the timing of it. And then the patient maybe went into recurrent DKA. So they started them on a drip and sent them to the ICU. Although the authors kind of reflected that, thinking back, they didn't even still need to send them to the ICU, because even if they had some rebound DKA, all of them still had mild versions or moderate versions of it. So they still could have just been restarted on the subcutaneous insulin. So this was a reflection that they had afterwards. So in general, it would appear that this shows that subcutaneous insulin is safe to use and effective for patients with mild to moderate DKA, reducing the burden of the need for ICU management. The one caveat would be that we have to ensure that our facility is able to, or that we're able to keep up with still checking those blood sugars every 2 hours and checking those BNPs every 4 hours. And the exact protocol, I have it up here, but it's also in the paper, which I think is on the chat, and we can post it in the chat later. So that's the paper. So some of the limitations of this was a single center. It wasn't technically an RCT, like it wasn't a randomized control trial. So they described it as a quasi-experimental, because they didn't randomly assign patients. They took patients based on the criteria that they had. There was some COVID at that time, so they had much lower volumes than they wanted for the study. They would have liked higher numbers for the study. Again, this is one center, and we need to, try it out at other centers. But like in the introduction, this has actually been tried in smaller on smaller scales and have still demonstrated the same efficacy. So this is like a pragmatic real-world study showing that this can be applicable to, different settings. The outcomes was ED length of stay. I wish they had measured hospital length of stay as well, because that would be valuable to know if, patients were staying on the floor, but they were staying much longer than they would have, or if the ICU patients were staying longer. So that's what I would like to see in future studies. So how I would apply this, I would say I'm swayed that subcutaneous insulin is a good pathway for patients that have mild to moderate decay and also don't have any concerning clinical features. I would just make sure that I have the resources to adequately manage them and have a contingency plan that if they do start to trend downwards, then they can be transferred to an ICU. So what do we think? Is this something that we've tried? Are there any concerns that we have about this paper, just hearing this brief summary of it? Maybe something that you think might not apply in your setting or something that applies in your setting. I would like thoughts on this.
Yeah, we'd love to hear if other people are using subcutaneous insulin and DKA. It can be a little bit less resource intensive, which I think is wonderful. I'm going to go ahead and launch the post-participation MCQs while people answer that.
Oh, this was done at your institution. That's awesome.
Yeah, this was actually at Washington University in St. Louis. So
yeah,
they did this study before I arrived. And so this was already a very well established protocol at our hospital. But it was, as far as I know, one of the first big studies of a subcutaneous insulin and DKA protocol. And so it's kind of caught on in other places. They've covered it on MRAP, like Emergency Medicine Reviews and Perspectives. So it was a big deal, especially during COVID when we didn't have enough nursing staff and everyone was dealing with a lot of other issues. So it was pretty cool.
Yeah. Yeah, I know how I feel sometimes when I have this like very well appearing DK patient that I have sent to the ICU, and I'm like, I don't feel like they need the ICU, but okay, you know. So I like this paper a lot too.
Yeah, having an in-between for the mild to moderate folks is really helpful. Is anyone else using subcutaneous insulin protocols for DKA at their hospital? We'll let people chime in the chat, Faith, if you want to move forward.
Yes. I think that's it. Most of this is just highlighting some of the key guidelines. So this is the American Diabetes Association, European Association of the Study of Diabetes joint consensus guidelines that came out in 2024. And many of these numbers are the numbers we had talked about earlier as well. So that would be this is for diagnosis of DKA. And of course, this would be depending on what your numbers are. So I think you said 13.3 millimoles per liter. The other thing is anion gap. I don't know that it was really necessary for diagnosis, but it was certainly one of the major things that we looked at, and now it's more de-emphasized in the recent guidelines. So fluids management based on these guidelines is the fluids starting with 1.1 to 1.5 liters in that first hour. Then they talk about switching to a half saline, that's 0.45 saline if your corrected sodium is normal. But you can also you can continue to use normal saline as well. Balanced crystalloid is accepted if that's what you have and what you want to use. Insulin starts with 0.1 units per kilogram per hour. That hasn't changed. What has changed is it's been de-emphasized to do the bolus. I think it used to say that if you anticipate a delay of starting the infusion, you can give a bolus of 0.1 units per kg. There's no real benefit to that. It increases the risk of, hypoglycemia, cardiovascular collapse, and all of that. So there's some risk to it. So you can only use it if you think that is necessary. You can't get an infusion for any reason. But I think that the subcutaneous version that we just talked about is a better way to do this. You can also use half of that, especially when you're transitioning to when the glucose is 250 or whatever the level is that you use. You can transition to half of that when you add dextrose to the fluid, and then they endorse the squid protocol in the guidelines as well, which is great. Then for bicarb, they just don't use it. Basically, they give some conditions where if you think there's cardiac compromise, severe hyperkalemia, you could consider it, but definitely don't use it routinely. Then this is their HHS guidelines, still similar. It's just a review of what we talked about, starting with fluids. This is more, instead of just 1 hour, do it over 2 to 4 hours. You can then switch fluids and add glucose as necessary. Go with insulin as well. And then these are the things to think about when you're for resolution. So with DKA, we had the 3 criteria. With this, you're also looking at your osmolarity. When it drops below 300, your urinal output is greater than 0.5 and your glucose is less than 250. The thing to note with this is that patients with HHS are very prone to VTEs, that's venous thromboembolism. So you want to think about thromboprophylaxis for these patients. Usually that's more of an internal admitting problem, but also something to think about if they're going to be in the ED for days. So I talked about this already. And then this is the pediatric guidelines. They changed, so this guidelines comes from this organization. It's part the bicarb level here used to be 15, but they've actually changed it to be similar to what adults are. So that's great because we don't have to memorize 2 different criteria. So this criteria is essentially the same as the adult criteria on making the diagnosis. The difference with the management is you want to go slower with your fluids. So 10 to 20 cc's per kilo. You can do that over 30 minutes and repeat. You want to go slower with the fluid, but also do it according to your patient presentation. So if they don't need fluid, you don't have to give them all of that fluid in the beginning. Then what else? Let's see. And then start insulin as well. So you can do a rate of 0.05 to 0.1 units per kg per hour. Similar management here to adults. Starts with subcutaneous insulin 1 to 2 hours before stopping the IV infusion. Don't give bicarb, absolutely, in this case, because bicarb has been shown to be associated with cerebral edema in children. So this is one situation where you don't want to give bicarb at all. So some things that have changed recently. So there is now this capillary beta hydroxybutyrate measurement. I haven't seen it. I don't know, Jess, if you've seen this, but it correlates well or reasonably to serum levels. So if that's something you happen to have available, that's a great way to hasten the diagnosis of DKA. And then, of course, there's more awareness about the glycemic DKA with broader use of SGLT2, something we're getting more comfortable managing and more familiar with. So some recent studies are showing balanced solutions over normal saline. There's no definitive evidence yet, so I wouldn't put so much input into that. The way I think about this is if you have lactated, if you have Ringer's lactate and it's not an issue to give it, then do. But if not, just give the normal saline without thinking too hard about it. Then the deliveries, operational deliveries, so things like your subcutaneous decay pathways are now gaining traction. And there are some institutions, like we talked about, that have established protocols for this. So that's really all I have. Like to hear what you guys do. And this is our summary. So I'll just run through the summary and then I would take comments from everyone. So fluids before your insulin, check your potassium levels. Always suspect euglycemic DKA if patient is on this medication. In HHS, assume a larger fluid deficit and start insulin later and do a lower dose of insulin. Consider subcutaneous insulin protocols as your institution, as these have been shown to be safe and effective. Always try to identify and treat the trigger of DKA and HHS. Avoid bicarb, avoid intubation, and in your pediatric patients that are at severe risk for cerebral edema, especially with those lab values that we talked about, you should prepare like hypertonic solutions. So whether that's your hypertonic saline or that's mannitol, to have that available. And these are my references.
Awesome. Thank you so much, Faye. We're going to go ahead and go through the multiple choice questions really quick before we
Okay.
wrap up for the day. So everyone should be able to hopefully see the correct answers now. I just published them. So for the first question, which of the following do you need to diagnose DKA? Everyone got that right. Wonderful. Hyperglycemia, acidosis, and ketosis. And actually the responses were improved from before the session. Set question 2, what is the hallmark feature that distinguishes HHS from DKA? Everyone got that right. Profound hyperosmolarity with minimal ketosis. Question 3, there was a little bit of division, but the first step in management of DKA is starting IV fluids. We don't start the insulin infusion immediately because these patients are very dehydrated. And then we also don't know the potassium right off the bat. So it could be dangerous to start insulin without that information. For question 4, in DKA, why can potassium levels appear normal or high despite total body depletion? And the answer is that there's a shift of potassium out of the cells. So 2/3 of you got that one right. And then everyone got the last question right. The medication class associated with euglycemic DKA is SGLT2 inhibitors. I want to thank everyone so much for their participation. And thank you so much to Dr. Faith Ibu for presenting and for Dr. Malik Lafaya for helping to make the slides today. If you did not submit feedback already, please do so using the survey that I just put in the chat again. And we will send out a summary as well as the recording shortly. And we just want to thank all of you for being here. And if you have any questions, we'll stay on for just a couple minutes here and you can feel free to ask questions. Thank you, Faith.
Just a quick one.
Yeah, go ahead, Emmanuel.
Yeah, just a quick one. Faith, wonderful. I listened to your presentation, spot on. Quite engaging.
Thank you so much, Emmanuel.
I love your science, your thought pattern, and your communication skill. They are quite highly commendable. For want of time, there are pocket stops that I'm going to share with Jess, quite all encompassing. Thank you. Well done. Well done.
Thanks, Emmanuel.
Thank you very much. I appreciate that.
All right. Thank you all. Thanks, Faith. Have a great rest of your day.
Yay. Bye, everyone.